Thank you very much for coming, and I will be speaking about the sensitive skin microbiome and some clinical cases which we have using the latest finding about the microbiome and implementing it in the applied cosmetic science. So first, before we're speaking about the sensitive skin, we should come to the question of the definition. And I can say that the situation is no better than with microbiome-friendly definition because we have no one. Sensitive skin is called by dermatologists sensitive or reactive or hyperreactive or intolerant or irritated. And all these names are pretty much official in different countries over the world and in Europe particularly. And all we know about sensitive skins, and it's very multifactorial and very diverse. So the skin sensitivity is characterized by so many sensations. Then it's difficult to choose one which can be the key symptom for the sensitivity. It can be tingling, it can be itching, it can be some kind of large irritation of the skin, it can be redness or not, it can be altered skin barrier, it can be literally anything. And it can be triggered by everything, by spicy food, by cold food, hot food, wine, hot beverage, cold beverage, wind, air pollution, air conditioner. So you name it, everything can trigger the sensitive skin. And when we speak about the sensitive skin in the cosmetic world, we are speaking mainly about the face. But we are not right, because about 75% of the patients who refer to their skin as sensitive have a dandruff, have a sensitive scalp, and has the sensitive body skin, including sensitive skin on genitalia in probably 43% of the patients. They don't want to speak about it, but we have this research showing that it's pretty much common. And if we summarize all factors involved in the sensitive skin development, there will be many of them. I just share in the three groups: cutaneous factors, external factors, and endogenous factors. Amongst cutaneous factors, today for us the most interesting is the dysbiosis, the unbalanced microbiome. But also we have genetic atopic predisposition, we have altered or disturbed skin barrier, which can happen under the influence of many of external factors. And also it is an involvement of the nervous system, which I don't see dermatologists and scientists I speak enough, but we cannot separate nervous system from the skin, as well as we cannot separate the microbiome from the skin. The skin, it is an ecosystem, but in the same time, it is nervous, immune, endocrine system. So we cannot speak about skin cells as them. We should speak about this core culture of the nervous, immune, endocrine, and skin cells. So we have, from the nervous system part, we have sensory nerves, we have expression of TRPV receptors, not only TRPV1 receptors, but also first type and second type, certainly, which are expressed in keratinocytes and nerves. And also we speak about the phenomenon of neurogenic inflammation, very much and very often triggered by bacteria, fungi, and probably viruses. In external factors, for sure, we have environment, we have climate changes, we have air pollution, and we have ultraviolet. One of the main factors triggering the skin sensitivity, because sun-damaged skin, it is the sensitive skin. It's almost equal. You being a dermatologist, I never seen the sun-damaged skin without the higher sensitivity. Also, it can be lifestyle, it can be food, it can be physical activity, diet, and cosmetic use and skincare use. And what we see in the last 20 years, we see kind of pandemic of sensitive skin. And I see, for example, especially during COVID, on our website, we notice that now about 75, 77% of visitors are going to the sensitive skincare. Because now it's probably about this amount of population are referring their skin as sensitive. And in my opinion, it's correlating with the use of so we called intense skincare, retinol-based skincare, acid-based skincare, which is largely affordable. It's on the shelf everywhere around the world. And substance use, different kind of life habit, and obviously endogenous factors. Hormonal balance, age-related changes. In women, it will be the menopausal changes, stress, and everything else. And when we are speaking about the overreactive skin, as I told, literally everything can trigger the skin reaction, from air pollution, temperature shift, cold climate, warm climate. What I found very interesting, then amongst all sensitive group patients, we see an increased presence of neurotrophic growth factor in the skin. When we diagnose the sensitive skin, there are probably a few dozens of classification of the sensitive skin. Once again, it's like microbiome-friendly claim. Everything. But these four classifications, they are kind of classic and probably they are most used by European dermatologists. And I'm using all four of them because they are not replacing each other. They are complementing each other. 𝐓𝐢𝐭𝐥𝐞 classification is very much focusing on the inflammation. So that's a group of patients with reduced skin barrier, increased transepidermal water loss, and extreme dryness of the skin. Another group of patients, they are patients with inflammatory changes without any decline of barrier function, and neurosensitive group of patients. So you see nothing, but they're still very much uncomfortable, they're sensitive. Milton-Berger classification focused on dermatosis. So active dermatosis out of remission. Group 2, the dermatosis with minimal signs or dermatosis in remission. And third group, my favorite, healthy people, but with the experience of trauma. So they are aesthetic patients. In the group 3, we see all patients after laser resurfacement, after all kinds of aesthetic procedures, chemical peels, and retinol users. And group 4, once again, did nothing, still sensitive. And classification based on the degree of the change, and classification based on factors and triggers, which are always useful to know. If we can find the triggers, we can avoid it if it is possible. But the diagnostic of the sensitive skin is a huge challenge because most of the time, even dermatologists, they refer to the subjective patient sensation, like, is your skin sensitive? 99% of people say yes to this question because they feel, yeah, I am a sensitive person, so my skin is sensitive. But luckily, we have some objective diagnostics, so we are using the sensitivity scale invented by Professor Laurent Misery in 2014. There are 10 questions. We have the biggest scale in 14 questions, but 10 questions are largely used. The most important thing about the sensitivity scale, you should ask using the phrase in the last 3 days. Because if you ask anyone, have you noticed any of this following without precising the timing, obviously everyone noticed something like skin irritability at least once in life. But it's significant when you notice this in the last 3 days, and we ask patients to score it from 0, which nothing at all, to 10, when yes, I noticed that for 72 hours it was painful, I couldn't forget about it, it's really impacted my life. And after we just get a total score, if the score is less than 20, so skin is resistant, objectively, very rare, nowadays. When I started practice in the mid of 90s, actually we didn't see so many people with sensitive skin, and about 20-25% of the patients being sensitive. Now it's vice versa. If we see 20% of patients with resistant skin, we are lucky. If the score is 20/60, the skin is sensitive, and if the score is higher than 60, it's very probable it is some medical condition behind it. Most of the time, it will be the dermatosis. So these patients need a dermatologist consultation. What do we know about the microbiome in the sensitive skin? This question was discussed yesterday many times. So we know the bacterial diversity is lower. We know that Staphylococcus epidermidis is underrepresented, as well as 𝐓𝐢𝐭𝐥𝐞 acnes. We know that Staphylococcus aureus is very much overrepresented, and we know that proportion of firmicutes is changed. And especially lactobacteria is slightly or sometimes even significantly increased, but it is not clear if it is correlation or causation or probably just some finding. As an extreme case of the skin sensitivity, it is atopic dermatitis. And in atopic dermatitis, we see everything. And especially we see overrepresentation of Staphylococcus aureus, which results in barrier integrity disruption because of the adhesion of Staph aureus to keratinocytes. We see the replication of Staphylococcus aureus leads to the development of the inflammation because of many different of biochemical phenomenon and changes, release of peptidoglycans, lipoproteins. We see that it can produce toxins, irritating and inflaming skin directly. But also the most interesting thing for me in the perspective of the therapy, then resolution of atopic dermatitis lesion is always preceded by the restoration of the microbiome. Until the moment when Staphylococcus aureus is prevalent in the lesion, you will not see the positive dynamic. Since the moment when we overcome this overrepresentation of Staph aureus, we see the clinical dynamic, we see the positive changes. Microbiome in the sensitive skin is less researched, but we understand that fungal diversity is opposite to the bacterial diversity. If bacterial diversity is lower, fungal diversity in the sensitive skin will be higher. And we see the decreasing abundance of Malassezia restricta, but in the same time, Malassezia racemosus is overrepresented in the microbiome, and Malassezia racemosus is pro-inflammatory fungi. It's inducing immunoglobulin E response in the skin. So it's literally kind of allergic reaction mediation. So it's very much involved in the skin sensitivity. And we see this niche competition between Candida auris and between Malassezia because both of them, they love long-chain fatty acid. So they compete about it, and it is also contribute to the skin irritation. And also Malassezia, it interacts directly with keratinocytes, and it secretes specific vesicles which signal to keratinocytes to secrete pro-inflammatory mediators. So it's just induce the inflammatory response in the skin. So the whole microbiome sensitivity hypothesis, based on the idea that the bacteria are interacting with keratinocytes, with mastocytes, mast cells, and then nociceptors and proreceptors of the skin. They are very much involved in this response. How they involved? Because nociceptors and proreceptors, they express the specific toll-like receptors. And these toll-like receptors, they react to bacteria and to fungi. So bacteria and fungi can directly stimulate nociceptors and proreceptors. And so skin microbiome influences not only the inflammatory reaction, but also migration, location, maturation of mastocytes in the skin. So it can diffuse allergic reaction, it can diffuse inflammatory reaction, and finally the whole skin sensitivity phenomenon. Why it's so important? Because the nervous system is absolutely inseparable from the skin. And it's literally the same organ. Embryologically, skin and nervous system being the same until 3rd week of embryo development. Only in the 4th week of the embryo development, ectoderm split to the 2 parts. First, just growing like a beautiful tree, contacting every cell in the embryo body, becoming the nervous system, and the second part, external part of the ectoderm, covering the embryo, becoming the skin. But they retain the similarity in the biochemical language and in the function. So when we speak about the microbiome interaction with the skin, we always speak about the microbiome interaction with the nervous system in the same time. I'm a big fan of Professor Misery, as you noticed. And he is the biggest authority in the skin sensitivity research. And that's just quoting him, then the nervous system controls all main skin functions. And I think we don't speak enough about it, and the understanding of the role of the nervous system in the skin functioning is very important also in the understanding of the microbiome role in the skin health and in all kind of development of the skin conditions. And TRP channels, that's the main structure involved in the release of neurotrophic agents and in the release of all kinds of pro-inflammatory mediators in the skin, causing this itchiness, flaking, redness, erythema, non-erythema, and all kinds of spontaneous, difficult to describe reaction, which we call skin sensitivity. What is very interesting, there are TRP channels expressed in all types of skin cells and nerve sending. But they can be activated by heat, cold, spicy food, any type of climate phenomenon, and microorganisms, bacteria and fungi. So skin sensitivity triggers all of them. And the last thing, which I think it's really probably undervaluated in our scientific discussion, it is the role of free water for the microbiome, especially when we're speaking about the skincare. Water is absolutely crucial for the microbiome, microbial growth. And in the dry skin, we cannot obtain the real recolonization of the skin because we need the free water to recolonize the skin and to get some therapeutic results. And water activity is really influencing the growth of microorganisms, but in the same time, classic moisturizers, emulsions, creams, they are not very active because they are improving the skin surface, but they don't increase the amount of free water in the stratum corneum. They bind the water to the stratum corneum, but the whole amount, the whole pool of the free water can be unchanged. So it's very important to use water-soluble products and water-soluble ingredients if we aim to promote some microbial growth. So the whole idea of the sensitive skin therapy based on the metabolic clusters and the metabolic changes followed by the colonization of the skin. And we know that skincare impacts the microbiome. We discussed it yesterday many times, but there are some research papers published, and this one I found very interesting. They really researched in all beauty of skincare impact on the skin and found that many of ingredients, they can stay on the skin for days and probably for weeks. But all kinds of changes, they are very much personified. They are person-specific, they are site-specific, and obviously they are product-specific. So the idea is to shift dysbiosis back to symbiosis because it's preceding the clinical progress. When you have symbiosis back, you have clinical improvement in skin sensitivity or all other skin condition. What can be the symbiosis disruptor? Literally everything, including skincare. So when we think about it and in the therapy, we should think about stopping the activity of this disruptor of symbiosis. And after, we can recolonize the skin with commensal microbes. And the most interesting for us, that's Staphylococcus epidermidis and 𝐓𝐢𝐭𝐥𝐞 acnes. So the whole approach of the therapy of the skin sensitivity based on the idea of topical metabolic shift with, in the same time, inflammation control by binding toll-like receptors. Actually, Staphylococcus epidermidis, it's a beautiful binder of toll-like receptors, but we can achieve the same result with cosmetic ingredients during the recolonization of the skin, and recolonization using probiotics or postbiotics, and obviously long-term use of prebiotics to maintain the symbiosis. It's a beauty to have an independent brand. You can experiment. So I started to experiment with this in 2017, and we have really great results. What we use for metabolic shift, I am using glycine, caprylyl glycine. It is lipacid from Solabia, which is pH modulator based on the amino acid, and it's efficiently suppressing the growth of Malassezia 4.4 and other Malassezia species. 𝐓𝐢𝐭𝐥𝐞 and 𝐓𝐢𝐭𝐥𝐞, both from 𝐓𝐢𝐭𝐥𝐞 is from Solabia, 𝐓𝐢𝐭𝐥𝐞 is from 𝐓𝐢𝐭𝐥𝐞. 𝐓𝐢𝐭𝐥𝐞, it's really good to promote the growth of beneficial 𝐓𝐢𝐭𝐥𝐞 acnes and Staphylococcus epidermidis. And 𝐓𝐢𝐭𝐥𝐞 is suppressing the growth of Malassezia as well. And for free water, all kinds of moisturizing ingredient, hyaluronic acid, aloe vera, carrageenan, glycerol, glycerin, and lipids, ceramides, squalane, skin-identical lipids. And for binding of toll-like receptors, I'm using northern truffle Albatross ovinus extract. It's Defensin Soft by Swiss ingredients company Run, which is binding efficiently toll-like receptors, prurireceptors and nociceptors, so it can be used like a very mild painkiller. But in the same time, it's really binding receptors, decreasing redness and decreasing skin sensitivity. So it's kind of replacement for staph epidermidis function. And recolonizing, I'm using symbiotics, EcoSkin, once again, Solabia. It's Lactobacillus acidophilus and casei in the inactivated form, but also 𝐓𝐢𝐭𝐥𝐞 and 𝐓𝐢𝐭𝐥𝐞 extract, which is rich in inulin. And clinical cases, we have really great results. So here it's a 35 years old female diagnosed with rosacea, 5 weeks use of this approach. So for metabolic shift, glycerin, hyaluronic acid for the free water, carrageenan as well, ceramides 3, and omega-7 fatty oil from macadamia, binding receptors with northern truffle, and recolonizing with symbiotics, EcoSkin, and prebiotics, 𝐓𝐢𝐭𝐥𝐞 and 𝐓𝐢𝐭𝐥𝐞. So, and what is interesting, then we are addressing the sensitivity skin with this approach, but we can address multiple skin conditions when skin sensitivity is the base of the skin condition. Here it's rosacea, also a young patient diagnosed with rosacea and highly sensitive skin, 5 weeks topical treatment, absolutely the same strategy, great results. It doesn't replace pharmaceutical treatment, obviously. It is cosmetic products, but it helps for treatment. It really complements the treatment because actually the biggest problem of the dermatological treatment, it is compliance. People don't use what they should use. In acne treatment, about 70% of patients, they are not compliant at all. And they're not surprised then they don't have results. And why they are not compliant? Because they don't see results quickly, and they really expect to get it in the first days of use, and they feel uncomfortable. The use of appropriate skincare restore comforts of the skin really quickly, gives this progress, and in the same time, it's beautifully complement the pharmaceutical treatment. Here it's from Australia, and this woman was diagnosed with psoriasis, and it was kind of torpid to the therapy. She didn't get results from the pharmaceutical therapy, but when the microbiome started to restore, her dynamic on the pharmaceutical therapy also restored. And after she been using pharmaceuticals and skincare at the same time, with really good progress. Another case of rosacea from Belgium, same approach, great results. Perioral dermatitis, also we can address exactly with the same approach, metabolic shift, free water, TLR binding, and recolonization of the skin. And the last one, it's just really, it's the first time in my life I've seen it, but one of our dermatologists, as we work with exclusively with clinics, and one of the dermatologists sends the results, it's diagnosed case of pityriasis versicolor. And they use the same approach, slightly different product. Here we are using also the anti-autoinducer from noni-plant stem cells. They are acting like they're helping to break the biofilm. And apparently it was very efficient as well. So the key takeaway, then patients with a sensitive skin needs more medical attention. And because very often what they say, dermatologists and skin practitioners, they don't take it seriously, because sensitive skin is like nothing, just discomfort. But it really impacts the quality of life, and it is the basis of many skin conditions. Skin sensitivity is the basis of rosacea, it's involved in the acne development, in many other dermatoses, so it should be addressed properly. And with the new understanding of the role of microbiome and nervous system, we can do it much more efficiently. Thank you very much. Thank you.